of the Office of the Medical Program Director is to support the people that do the work. Here's the outline for today. I'll give some brief updates. We'll talk about the definition and the pathophysiology of shock. And then we'll talk about the different kinds of shock, and we'll separate into shock that involves the pump, okay, and testing audio now. Okay, got a hardwired connection now. This should be better. Okay. Okay. So just some brief updates. Obviously, the protocol app has gone live. I just want to call out one thing. We have pulled out the resource phone list and moved all of the phone numbers into contacts. The advantage of that is, one, you can just tap on your device and call any number from there. Two, if we need to make any updates, it'll make those automatically without you having to update the protocol app. Do want to call out that we have at the top of the list the number for online medical control. Right below that, there's a number that is online medical control just for Peace Health. For example, if you're transporting a patient to Peace Health and you need to just reach the Peace Health docs. Remember, with the main online medical control number rings to the EMS docs first. Right now, 40% of the time, those calls are being answered by either me or by Dr. Gadwa. So we welcome any questions about that. As we discussed in January PCEP and worked on in the skills sessions, our primary quality aim for 2025 is to improve our performance on Airway 01, which is first pass success without hypoxia or hypotension, to 60% by December 2025. I'll give you a brief update on how things look with that. So here's our current performance going from April 2023 to January 2025. And I'll fill in what we know about February and March so far. So overall, for Airway 01, our baseline is about 17%, and that's pretty close to the national average. This is a hard metric to hit. What I can tell you is that in February, we were up to 40%. I called that out in the monthly update. I think that reflects tremendous hard work, and I can tell that people are really putting a lot of attention into making sure that they've resuscitated patients before they proceed with intubation. The first 3 cases we have with March did not meet the measure. So again, I have some specific ideas, and I want your ideas about how we can improve that. And so where is it when we don't meet the measure? Where are we not meeting the measure? So in general, we do pretty well with first pass success. Baseline for that hovering around 80%. We've got tricks and ideas and some things that we'll work on to improve that, but generally that's not why we're not meeting this measure. We're doing relatively well with oxygenating our patients prior to intubation and making sure that that's recorded. So that baseline is around 75%. Definitely room for improvement, but that's not the place where we're missing this measure most commonly. The place that we most commonly miss this measure is getting a systolic blood pressure within 3 minutes prior to the intubation. And we'll go into this, and this obviously relates to what we're talking about with shock. But the reason this is important is that we're doing an intervention that can throw our patients into shock if we haven't fully resuscitated them. So we want to know where we're starting from. We want to know that we've done the things necessary to resuscitate them before we proceed with intubation. And so today we'll talk about shock, but I want you to think about how this interacts with the airway measure and how we can safely intubate our patients. Okay. We'll go into the definition and pathophysiology, but my goal here is that we're going to end up with a practical approach for especially when the cause of the shock isn't clear. I'm going to give you some steps that you can work through to troubleshoot this. Okay. So we'll start off with a question to get you thinking. So dispatched priority 2, unconscious party. So the report is that this patient had been getting worse over the last several days. We arrived to find a 64-year-old man. He's got a history of rheumatoid arthritis. Can't find the med list. He's oriented to person only. His heart rate is 75. His blood pressure is 75/40. His respiratory rate is 24. CBG is 75. So for this patient, what do you think are the most likely causes of shock? Go ahead and go to Slido, and I want to hear what you think here. I'll go back for a second just in case anyone wants to see the case again. And Mark, any questions or comments in the chat or any logistical issues with this one? And temp is 96. People some time to answer. Yeah. I'll just give a little bit more time for people to answer. So what I'm seeing from the group, primarily septic shock is the most likely thing. Septic shock is probably the most common cause of shock. And if you start with treatment for septic shock, you're never going to be wrong in this case. And the other thing I would say is think about hypoadrenal shock in this patient. Patients that have rheumatoid arthritis are generally on steroids. And so this may be a steroid dependent patient. The other things that make you think that this might be something else is his heart rate's not that high. And then the blood sugar is on the low side. The temperature is on the low side. But that said, we don't know. There's a lot of uncertainty in these patients that we're dealing with. And so that's why I want to give you a practical approach for when the cause of the shock isn't clear. How do we think through this? How do we troubleshoot it? So what is shock? It was defined by the Civil War surgeon, Samuel Gross, who saw plenty of shock. He was one of the people who developed the tourniquet for use in the Civil War. He saw thousands of people die, and he described it as the rude unhinging of the machinery of life. It's this profound dysfunction. And so we're going to get into the nuts and bolts of what that looks like and what is actually going on there. Okay. So if we put it into scientific terms, it is that the oxygen delivery is less than the oxygen demand. So we'll go into what constitutes oxygen delivery. Oxygen demand is the tissue's demand for oxygen. And so when we think about what we can affect in EMS, we can affect the oxygen delivery. There's not much that we can do about the oxygen demand. We can give Tylenol to a febrile kid. That'll reduce the oxygen demand a little bit. But there's really not much that we can do about the oxygen demand. The lever that we have to pull is oxygen delivery. And I want to give you a chance to kind of think about what this feels like and what this looks like just from your daily lives. So think about what happens if you are exerting yourself, you're running an interval, and your heart rate gets up, and your breathing gets faster, and then your breathing gets faster, your legs start to burn. What's happening there? Does anyone online want to offer, like, what's happening? You're running an interval, your legs start to burn. What happens there?
Acidosis.
Yeah, acidosis, exactly. So you're moving from normal aerobic metabolism into anaerobic metabolism. And so you're healthy, your body does the things to compensate. You can do that for a period of time, and then at some point you can't do that anymore. And if you're healthy and you're exercising, you're going to slow down because you just can't do that anymore. So our patients are in this state where they are moving into lactic acidosis. They need more and more oxygen. They can't keep up with the demand. And the only things that we can do are to improve their oxygen delivery, to try to keep them from going into the acidosis that leads to this spiral. So what constitutes oxygen delivery? Break it down. So it's the cardiac output times the oxygen content. What's the cardiac output? Cardiac output is heart rate times stroke volume. That's your cardiac output. What's your oxygen content of the blood? It's your hemoglobin times your oxygen sat. So how much hemoglobin do you have? How much oxygen it is able to carry. I've learned this is, think of a freight train that's got empty boxcars. And so how many boxcars do you have? And how many of the boxcars are full? Those are the things that make up oxygen delivery. And so how, with the information available to us, do we figure this out? So heart rate and stroke volume correspond pretty darn closely to the heart rate and the systolic blood pressure. That's going to give you a rough idea of, so heart rate is heart rate, stroke volume roughly correlates with the systolic blood pressure. And then hemoglobin and oxygen saturation, how do we figure that on the field? Is there blood on the floor? And what's the SAT? And obviously, sometimes the blood is in the belly, sometimes the blood is left behind on the scene, but there are a lot of clues that you can get on scene as to this patient is low on hemoglobin. So these are things that we can assess. We have the tools to know what's going on, and then we can make some intelligent guesses about what's going on with the patient. So one of the key things, and one of the things that we can most affect, is the heart rate and the systolic blood pressure. So the heart rate and the systolic blood pressure is the shock index. Heart rate divided by systolic blood pressure is your shock index. And if there's one number that gives you a quick sense of how shocky this patient is, that's the number. So a shock index of less than 0.7 is normal. So for example, that's so if that's the ratio, then that's essentially normal. 0.7 to 0.9 might be early shock. And if it's greater than 0.9, then that's a high risk of shock. So think about, that would be heart rate of 100 and a systolic blood pressure of 90. You're likely getting into shock territory there. Essentially, once the heart rate starts to get greater than the blood pressure, your patient is likely in shock. I also want to point out, you don't need to do math to recognize someone in shock. This is an important tool and can help you think about it. But another thing that really helps is the view from the door. So clinically, how do you recognize someone in shock? Biggest things that we see are the skin signs, because when the skin is the largest organ, it's external. One of the first things that happens as the body goes into shock is that there are changes in the skin. And then because the body's priority is to perfuse the brain at all costs, you're going to see changes in mental status. And the military blood transfusion algorithm isn't based on any numbers. It's just based on mental status. So the idea is we're going to transfuse this patient until the patient is making sense, the patient can talk to us. So those are the most important things. Never want you to lose sight of that big picture that you're walking in the door. Oh man, this person looks terrible. Has anyone heard of the LLS score? It's a Scott Weingart thing. So if the patient looks like shit, the LLS score is 1. And so again, it's important just never to lose this view from the door, especially because you're generally not going to be misled about the pulse. But with an auto blood pressure cuff, you can be misled about the blood pressure. So I want you to be taking these vital signs into account, but also taking it into account with your clinical impression. Because our primary role, as we talked about before, is we drive oxygen to the heart and to the brain. And so when we see altered mental status, when we see these changes in skin signs, that's our sign that the patient is going into shock. What happens when the patient goes into shock? There's a stage of compensated shock where you will see vital sign changes in response to the shock. But the patient generally is still mentating appropriately, generally is still maintaining perfusion. Then decompensated shock, that's when you see the mental status start to change. That's when you see more dramatic vital sign derangements, more dramatic skin signs. And then you will get to a point where shock is irreversible because patients will get so acidotic that there's this cascade of things that happen. Particularly in trauma and hemorrhagic shock, they get coagulopathic. And so then they just continue losing more blood and you can't, they've fallen off the cliff and you can't get them back. In septic shock, similarly, they get so leaky, they can't perfuse. And you can't do anything to, got the patient on multiple pressors, you can't get them back. So we try to catch this early because once they go over that cliff, it is irreversible. So I'm going to bring back a slide that we talked about in the January PCEP. So we talked about why we resuscitate patients prior to intubation. This is essentially an illustration of what happens if we haven't resuscitated patients and they go off that cliff. So in intubation, if the systolic blood pressure is less than 100 millimeters of mercury, the risk of post-intubation cardiac arrest is 6 times higher. If the SAT is less than 90%, the risk of post-intubation cardiac arrest is 3 times higher. So it's essentially, we've got a patient that's on this precipice, and then we do something that affects their body physiology, and they can go over the edge. That's why we care so much about Airway 01. But the shock index is such a powerful predictor of what's going on with the patient, and it's shown across multiple pathologies. Here are just a handful, here are just 2 papers, but you can look at shock index and mortality, and you'll see tons and tons of papers. And specifically, the pre-hospital shock index is the best predictor of mortality. It's what happens before we start doing stuff to them. And so in trauma, if you have a patient that has a shock index greater than 1.3, they are 5 times more likely to die. In CHF, if they have a shock index that's greater than 1.3, about 4 times more likely to die as well. So it's a powerful predictor. Okay, we'll go to another question. So heart rate's 120, systolic blood pressure is 90. What is the shock index? As a reminder, you can either scan that QR code or you can go to slido.com and enter that number. Either of those will get you to that question. Like that. Is that working on your end? Okay. No, and I'll definitely want you if you. A little bit more time. Are you able to see how many responded? Or how many so far? Yeah, okay. Okay. So the answer here is, I'll give people just a little bit more time. Okay. No, and thank you for your answer. So the answer here is 1.3. So heart rate divided by systolic blood pressure, 1.33. But the key thing to take away is just you don't have to do math. It's just if the heart rate is significantly higher than the systolic blood pressure, this patient is in trouble. And again, this is something that is definitely within the EMT basic skill set, and this is something that an EMT can remind the paramedic about. Just keeping an eye on these basic numbers and seeing how they change over time is one of the best things that we can do to gauge how our treatment is working for the patient. Okay. So we're going to talk about causes of shock. We'll go in this order. We'll talk about the fluid, the pumps, and then the pipes. Okay. So obviously the fluid, that's the blood that's circulating. The pipes are the blood vessels all the way down to the capillaries. The pump is the heart. So what can go wrong with the fluid? Basically two flavors. Okay? You're either dealing with hemorrhagic shock, where typically you'll see an elevated heart rate, decreased blood pressure. You typically see this pale and sweaty skin because they have this sympathetic dump, and there's some source of blood loss. This is typically present either on the history or the physical. You've got some indication that there's some kind of blood loss. These patients will tend to look anemic, they're pale, there's some sort of blood loss. The problem in terms of what's going wrong with the oxygen delivery is both stroke volume, there's not enough volume, and there's not enough hemoglobin. So non-hemorrhagic shock that's related to the fluid is you're just down on fluid. Amount of hemoglobin is okay. The heart rate is increased. The blood pressure is down. These patients will typically look really dry. I don't know how well it projects. That's a raisin. These are the patients that have, you pinch their skin, it stays up. Their mucous membranes are dry. The typical history is some kind of fluid loss, whether it's exertion or vomiting and diarrhea for multiple days. There's typically some clue that these patients are just dramatically fluid down. And so here, the only problem is stroke volume. So what's the treatment for hemorrhagic shock? Stop the bleeding and give blood. And that's really the only things that are effective for hemorrhagic shock. That's why we limit the amount of IV fluid that we give in a trauma patient. So you can fill up the sweat that they lost while they were, running, trying not to get shot, but blood is really the answer there. And that's why we're starting to do some preliminary research to figure out if that's a feasible intervention in our system in the future. Because that is really the only treatment for hemorrhagic shock, whether it's trauma, whether it's GI bleed, whether it's OB hemorrhage. The only treatment for hemorrhagic shock is blood. And patients that get blood improve dramatically, and patients that don't get blood, unless we can stop the bleeding and you start to give them blood back, we're just not going to reverse that coagulopathy, and we're just not going to reverse the essential pathology. There's no replacement for hemoglobin being able to carry blood. For non-hemorrhagic shock, the treatment is to give fluid. And the good thing is these patients really tend to respond well to the fluid that we're giving them, and you're going to see response in the vital signs relatively quickly over the course of 5, 10, 15 minutes. You're going to see a response if the patient is dry and what they need is fluid. And now we're going to talk about the pipes. So this is distributive shock, and there are different flavors of distributive shock, but the essential problem is the same. It is that you have the stroke volume, but it's just ineffective because it doesn't get to the tissues, primarily because it's leaky. They're leaky capillaries. It's just, you don't have the pressure differential to drive the oxygen into the cells. So septic shock, in general, you see the highs and lows of temperature. You see an increased heart rate. You see the drop in the blood pressure. Early in septic shock, patients can look flushed as they're febrile. Late in septic shock, they will get mottled skin, and that's because you've just got these, some capillaries, there's some blood getting through, some capillaries there's not. Everything's really shut down. Anaphylactic shock obviously has other signs with it, but you will see the increased heart rate, you'll see the decreased blood pressure, and those patients will typically also have pale and sweaty skin. There's this massive sympathetic dump. They're trying to compensate with that. Neurogenic shock is quite rare, but that's just a loss of the sympathetic tone. For that reason, because they lose sympathetic tone, because there's generally some spinal cord damage, they will often have a decreased heart rate, decreased blood pressure. The skin is dry because they don't have the sympathetic tone to produce the sweating. And it's often flushed because there's a fair amount of blood there, but there's no sympathetic tone to provide that blood pressure. And then hypoadrenal shock, the biggest clue is the history. The heart rate tends to be normal, maybe slightly elevated. The blood pressure will be dramatically low. And then the skin is typically pale and clammy. They're able to form that sympathetic tone, but they don't have the steroid to manage their electrolytes to make everything else work in the system. So how do we treat distributive shock? Fluids and pressors, and then with hypoadrenal shock, we add in steroids as well. The treatment for each of these is the same. And so they will typically respond quite well to fluids. If you're not seeing the response to fluids, then that's when we add in the pressors. And then hypoadrenal shock, you're going to start with the fluids and the pressors. And then if you have that piece of the history, you're going to add in the steroids. Okay. And then last one is pump problems. And these come in two flavors. One, the problem is with the pump itself. That's cardiogenic shock. Or the second is something is blocking the pump, and that's obstructive shock. So in cardiogenic shock, if it's a rhythm problem, we're typically treating the rhythm with electricity. Either that it's too high and we're cardioverting, it's too low, we're adding pacing. Too low, we have the option of a few meds to help us as well. And then we're going to improve the contractility of the heart with pressors. In obstructive shock, the one that's treatable in the field is tension pneumothorax. And so we decompress the chest for that. A massive PE can cause obstructive shock because you've got some clot on the right side of the circulation. Pericardial effusion can cause obstructive shock, but these are rare, relatively hard to diagnose. There's no pre-hospital treatment. So I don't think it's worth spending too much time thinking about that. When you think about obstructive shock, it's generally trauma patients that have a tension pneumothorax. If there's the rare case, say someone has a spontaneous pneumothorax and that develops tension, that could happen, but that's quite rare. Far and away the most common cause of obstructive shock that we deal with in the pre-hospital setting is tension pneumothorax from trauma. Okay. So we've already started to talk about, talked about the treatment and talk about the recognition. So cardiogenic shock, you can have a very elevated heart rate, so something greater than 150, where it's a primarily rate problem. You may have a very low heart rate if it's the bradycardia that's the problem. You'll have this decreased blood pressure. And then the thing that's really distinctive about cardiogenic shock is that the patients rather than looking pale, they'll often look blue because they're just not getting oxygenated blood to the extremities. One of the, you think about all the causes of distributive shock, almost all of those, you grab the extremities, you grab the toe is going to be warm because there's blood going down there. It's just not getting into the tissue. In cardiogenic shock, the extremities are going to be cold. Everything's clamped down. The body's trying to increase the systemic vascular resistance as much as it can to perfuse the heart and the brain, but the extremities are just going to be shut down. And then in a destructive shock, tension pneumothorax, you may have the absent breath sounds, you may see the JVD, but the most important thing is to suspect it clinically if you've got someone with blunt chest trauma who is in shock. Okay, we'll go to another question. 35-year-old male, unrestrained driver in a motor vehicle collision, heart rate's 116. It says Dorf on his chest. There's a faint carotid pulse, no other pulses are palpable. Patient's in spinal precaution in the ambulance. Put your treatment plan in order. It's you try it. It's in the back of the ambulance. It's just really, really noisy. Okay. So here's the consensus of the group on the order of treatment. And I think this makes a lot of sense. Obviously, this patient, you have to presume there can be hemorrhagic shock. You want to start transport and get them to a place where you can get blood and get definitive treatment. Oxygen is a quick thing that's going to help and start. But the key thing for this patient is peri-arrest, has blunt chest trauma. You got to suspect the tension pneumothorax. I think it makes a lot of sense to dart both sides of the chest in a patient like this. If you don't have, if you can't see a clear sign that it's on one side or the other, dart both sides of the chest, because that is going to be the most reversible cause of shock in this patient. And all that can happen before you get IV access for a fluid bolus. Because remember, a fluid bolus is going to be of limited value in this patient. Key things are we need to treat the reversible causes of shock in this patient. So here's a case where I think it's relatively straightforward, but we know in real life, it's often not that straightforward. And so what I want to do is to give you a practical approach for when it's not straightforward. How do you think through it? I'm going to make an analogy and use it if it's helpful for you, and don't use it if it's not helpful for you. Obviously, I know a lot of the people listening to this are dual role EMS and fire. And I was talking with Chief Noor from CCFR about this yesterday, just to make sure that my thought process made sense. But I think of this a little bit as, if you're the engineer and you're on a working fire, and then all of a sudden you lose pressure on the end of your hose, how do you troubleshoot that? And that's the mindset that I'm hoping to get you into here. And so I was talking. I said, so Chief Noor, you're doing this. When you lose pressure on the end of the hose, like, how do you think through this? And he says to me, well, one of the first things I was taught is, like, when you're doing this, running the pump, like, you keep your foot on the supply line. You got to know that you have the supply. And then, okay, and then if you know you have the supply, then you look downstream, like, is there something leaking out on the other end? Is there a problem elsewhere? And then that's when you go to the pump. Is the pump racing? Is the pump going really slow? And try to fix the pump. And that is pretty analogous to how I think about, I got a patient in front of me doing terrible, and they're in shock, and it's not clear why. How am I going to go about fixing this? So here's an approach that I would suggest. So check the fluid. So look at the patient and say, what's the fluid status? Is there blood on the floor? Does this patient look super dry and have a history of vomiting for a week? Or is this patient clearly fluid overloaded? There's 4+ pedal edema. There are rails to 2/3 up the chest. Okay. I checked the fluid. That patient with 4+ pedal edema, rails to 2/3 up the chest, there's plenty of fluid. Fluid is not the problem there. But if in doubt, give a fluid bolus and see what the response is. And over the course of 5 minutes or so, you're typically going to see some response to, if a patient is fluid down, they're going to show you and they're going to respond to the fluid. And then you can give another bolus and see how they respond. And then if they get to the point where their oxygenation is worsening, and it's not helping this primary problem that you're trying to treat, then that's when you back off and start to think about something else. So first step, check the fluid. So you've got a reasonable sense that you've filled the tank, the fluid is okay. Then the next step is to tighten the pipes. And because then the next most likely thing you're dealing with is some kind of distributive shock. And so typically that's why we have norepinephrine as our first line pressor. If you have a reason, say, for example, anaphylactic shock, to use epinephrine, then that makes complete sense as well. But fill up the tank, and we see, okay, can I get the pipes better? Does that fix the problem? And then if that doesn't fix the problem, it's still not clear, and you're all the way up on your pressors, then that's when you need to look at the pump. And so that's where you could say, if you have norepi, you add epinephrine. We're doing some more with respect to the contractility. You ask yourself, could there be some other pump problem? Could there be some other cause of obstructive shock, a PE, a pericardial infusion? That's where you start to think about the pump once you've taken care of the fluid and the pipes. Remember that in a trauma patient, fluid is, once you've dealt with tension pneumothorax, the problem is that you're losing blood. And so in that case, tightening the pipes doesn't help us all. Those patients have plenty of epinephrine. They are doing everything they can to increase their sympathetic tone. But in a trauma patient, you can't move past that fluid step, because what they really need is blood. Any questions about that approach before we go into a few more quiz questions? Anything online? Okay, so we'll go ahead and go into some questions. So 64-year-old man, heart rate 130, blood pressure 90/50, temperatures 1 and 2.5. First, what is the first treatment for shock? We're starting to get some response online. Are you able to see? And I agree. So, there's consensus here. This is the patient, likely septic shock, has a fever, clearly is tachycardic. Is tachycardic enough to say, for you to notice that the rate is fast, not tachycardic enough that the rate is a primary problem. So cardioversion is not the answer. And you don't want to add in norepi or epi until you've filled up the tank. Okay. So 55-year-old female, heart rate of 170, systolic blood pressure of 80, diaphoretic, and AFib with RVR. First treatment for shock. Do you have the responses online already? Okay. Okay. This is a patient with cardiogenic shock, primarily because of the rate. So the answer is synchronized cardioversion. Number one, if in doubt, patient has a significantly tachycardic and unstable, we're going to go to cardioversion. Low dose epinephrine, although this patient is quite shocky, if you give low dose epinephrine to this patient, it will likely get more tachycardic, so you're not fixing the problem. A similar issue with norepinephrine, and in this patient, IV fluid bolus is not the first step because you have a clear case of cardiogenic shock related to the rate, and so you need to move straight to treating with that. So just as a reminder, with respect to Airway 01, we're continuing these cycles of plan, do, study, act to try to figure out how we can get better. And this month, the focus is on getting that blood pressure prior to intubation. We've got the new checklist rolled out. What we've decided is we're going to take the feedback from all the crews and work on monthly updates to that checklist to make it as practical as possible for the people who are using it in the field. We want your ideas on that. Feed that up through your training officer. You can also go to clarkmpd.org/feedback, and there's a place to find ideas. There is no question that the people who are doing this work every day are going to have a better idea of how to fix this and how to perform better on this measure, than the people that are in the MPD office. With that, I'll wrap up with take-home points. So remember that shock is oxygen delivery less than oxygen demand. The thing that we can affect is the oxygen delivery. The patient looks terrible, assume shock. Especially, there's not a primary airway issue, there's not a primary breathing issue. Assume this patient is in shock. The shock index, heart rate divided by systolic blood pressure, predicts mortality. So really good sense of how sick your patient is, and a really important clue as you triage them and come up with a treatment plan. If a patient gets into decompensated shock and we can't fix that, that universally leads to death. Shock can be caused by problems with the fluid, pipes, or the pump. Remember, fluid is either hemorrhagic or not hemorrhagic. Problems with pipes, distributive shock, septic, anaphylactic, hypoadrenal, or neurogenic, or problems with the pump. Problems with the pump are either cardiogenic shock or obstructive shock. If the cause of shock is unclear, first troubleshoot the fluid, then troubleshoot the pipes, then troubleshoot the pump. Take any questions from the audience. Let me know if there's anything in the chat. And Mark, any questions in the chat? Okay. And then then finally, we want your feedback on this lecture, especially tried to make this more interactive. And so I really want your feedback on how that as a general approach and how this tool works in terms of making it more interactive. Just as a short list of some of the changes that we've made in response to your feedback. Number one, we're keeping PCEP shorter. Number two, making sure more appropriate to call out the things that are critical at the EMT level. But my intention is to continue to improve this, to make it the best possible continuing education that we can give. So you can scan this QR code, you can go to that link, and also post this link into the chat. Thank you very much. I really appreciate the attention and your feedback.